Welcome to expert insights from around the globe on tailoring treatment for patients with atopic dermatitis. Thank you to PeerView for providing this session and Sanofi Genzyme and Regeneron Pharmaceuticals for providing the educational grant for this webcast.
Hi everyone, we are really excited today on this expert insights from around the globe on tailoring treatment for patients with atopic dermatitis. So welcome to expert insights from around the globe on tailoring treatment for patients with atopic dermatitis. I'm really happy to be joined today. My name is Yassky, and I'm really happy to be joined today by Kenji Kabashima and Jacob Thyssen, one from Japan, Professor Kabashima, and one from Europe, Jacob Thyssen, and I'm from the United States. And look out for poll questions we'll be posing during the session, and ask questions to the faculty by entering them in the space provided. So my disclosures and my colleagues' disclosures. So watch for the on-demand version in the coming weeks and download the slides and practice aids and apply for CME credits. And if you need more information, please send an email to live@peerview.com and visit us at peerview.com/atopicderm2021 and join the conversation also on Twitter. So the agenda. This is a case-based demonstration and instruction of global approaches to the management of atopic dermatitis, and will incorporate it throughout the program using a theme and variation approach, with us discussing different issues and cases for atopic dermatitis patients among us. We will assess disease severity and initiating treatment. We'll explore the use of targeted therapies to manage moderate to severe AD in adults and children, improving treatment adherence, and engaging patients and caregivers in the care. So be prepared to answer follow-up questions throughout the program and after the scientific sessions. So now I will start briefly on my thoughts on managing AD and how we should assess disease severity and initiate treatment. So again, I'm Emma Yassky. I'm coming from New York City. I'm the Waldman Professor and System Chair of the Kimberly and Eric Waldman Department of Dermatology at the Icahn School of Medicine at Mount Sinai in New York. We'll start with a little bit introduction on atopic dermatitis, although I'm sure that many of you are familiar with atopic dermatitis. It's important to remember that this is the most common inflammatory skin disease in both adults and children. The prevalence of AD is estimated to be 15 to 20% in children and 1 to 3% in adults, although in the United States it's higher, is up to 7%. The disease course is commonly chronic in adults and more relapsing remitting in children, and the burden of symptoms can be profound, really impacting the quality of life of patients. It all starts with the intractable itch that patients have, inducing sleep disturbance, but also depression and anxiety, and many other comorbidities. And systemic treatments are commonly used for the patients that have moderate to severe atopic dermatitis that is not controlled with topical treatments and that have impaired quality of life. In terms of distribution of ages, atopic dermatitis starts early in infants, but for many infants progresses to childhood and teenage years and adulthood. And many times we also have it starting in childhood or in adolescence. And we even have cases that start in adults. Some examples, many times we see that atopic dermatitis involves the folds, as you can see here, and that's quite common in most patients, but you can see it very clearly in patients with lighter skin tones. And atopic dermatitis in darker skin tones, very important to differentiate just dry skin in dark skin or black patients as compared to patients with severe disease. But it is important in Black patients to assess the disease carefully because we do not see the erythema that is so evident in lighter skin tones. On the other hand, they have prominent lichenification, really a very prominent thickening of the skin in many locations, unlike patients with lighter skin tones. And also, many times, particularly when they have resolved lesions, these lesions resolve with dyspigmentation that we need to be really attuned to. And also, they many times will have follicular or papular or nummular morphology that is much more prevalent in darker skin tones. Now, just mild or localized AD, many times mild AD is a localized AD because body surface area is important in atopic dermatitis. And just some examples, depending on the skin tone, you see it in dark skin and you see it in patients with lighter tones. So you see some hyperpigmented, hypopigmented, or just pinkish erythematous skin, no crusting or oozing, barely swollen or thickened skin. A moderate atopic dermatitis, you see more dull red skin, clearly swollen, raised, or thickened skin with mild oozing and crusting that might be present. And severe atopic dermatitis, bright or deep red skin, very swollen, raised, or thickened skin, and oozing and crusting may be present. And here body surface area does come into play because the rash is often widespread. So we have several tools to objectively assess the severity of atopic dermatitis: the EASY scale that is up to 72 and the SCORAD that is up to 103. And we also have the validated assessment for atopic dermatitis, the validated IGA, that is also utilized in clinical trials, that was recently modified, and it's being used now, the VIGA validated IGA, in multiple clinical trials. And we have some subjective tools, such as a quality of life assessment tools, DLQI, POEM, and a pruritus NRS that is very important because each is the hallmark symptom of atopic dermatitis. Now, when we consider atopic dermatitis, we need to think also about the comorbidities of patients, and primarily the atopic comorbidities. And we need to remember that atopic dermatitis is the first step in the atopic march. And after the atopic dermatitis starts, many times it's followed by other atopic comorbidities such as food allergies that start around 1 year of age, and followed by asthma and allergic rhinitis. And many times our patients will have more than one comorbidity. Now, it's important to remember that there are several guidelines and also some publications in lieu of guidelines, such as the yardstick, because guidelines are happening only once every few years, and they are not updated many times to include newer treatments. So I participated myself in the AD yardstick that tried to incorporate the newer treatments at the time, such as dupilumab and crisaborole, that were not yet incorporated in guidelines. And the same happens with the European guidelines. So on one hand, you have guidelines. On the other hand, you have some position papers that are trying to incorporate newer treatments, such as you see on the right side, that are not yet part of the guidelines. So now let's discuss a case of a patient with atopic dermatitis that has widespread lesions all over the body. The patient has atopic dermatitis since childhood. It was most of the time mild to moderate. He was able to control it mostly with topical treatments, but it got progressively worse throughout life. And then it got much worse after the patient started to use multiple doses of oral prednisone. And after the oral prednisone was started, of course, lesions disappeared, but eventually the disease got out of control. And the patient, when I saw the patient, he was already on his fifth dose of oral prednisone in 1 year, a widespread disease, crusted lesions, weeping, needed also multiple courses of antibiotics. So, what are you doing in such a case, Jacob?
So that's a great question, and I think it's a typical case. So basically, what I always do, and that goes for both children and adults, is I want to make sure that they adhere to the treatment and they follow all the recommendations we have. And I'm sure that in this particular patient, if you optimize topical treatment, it won't solve his problem. But I always do that because, as I will explore later in my presentation, is that we do come across these patients that have misinterpreted and misunderstood the danger and risk of using topical corticosteroids, and therefore they fail. But as I say to them, if the product doesn't come out of the tube, it's not going to work. But anyways, I try to optimize that. And if that doesn't work, then I present to the patient the various treatment options we have. So I'll say in the near past, that has been the traditional systemic immunosuppressants. Methotrexate, most notably, is the one I prefer. We don't use cyclosporine that much in my country, and I think it has to do with the brevity. We can use it; it's 1 to 2 years, and then you have to take the patient off. And basically, what I look for is a long-term treatment solution. And now we have dupilumab, and I think we have several years of experience. It's a wonderful drug that works nicely. Also have very good experience with methotrexate, as said. And now in Europe, we have the benefit of also having access to baricitinib. So those are the three predominant treatment options that I would consider in a patient like this.
And what would you do, for example, a patient that was on oral prednisone? Let's say you want to put the patient on dupilumab. Would you do a small period in which you give both methotrexate and dupilumab just to take him off the acute exacerbation he had, or how would you tackle this?
That's a good question. I think the challenge here is, so if you have a patient on prednisolone, when removing that, we fear that you will have this flare. The problem with methotrexate is it's so slowly acting. So likely there, I would prefer cyclosporine because it acts so quickly within a few weeks. So I would remove the patient from prednisolone as fast as possible, replace it with cyclosporine and dupilumab. But I must say, even though it has a slower kick in, dupilumab, compared to some of the new JAK inhibitors, I think it has a sufficiently fast onset of action. So the bridging hasn't been that important in my clinic, at least. But I'd be very interested to hear the experience from Japan and from your clinic, Dr. Gottman.
Yeah, Kenji, what is your experience in Japan with such patients?
Yeah, so we have very similar situation in Europe. We have very similar guidelines, and also we have very similar choices, except methotrexate is not allowed to use in Japan. But other than that, we are exactly the same as Europe.
And in my clinic, very similar to both of your clinics, what I would do in such a patient, I myself, well, I agree with Jacob completely about the requirement to monitor cyclosporine and so on. But since I don't use it for long term, I like to use it sometimes short term to put off fires like this one. So what I would typically do, I would put the patient on dupilumab, but I would add a cyclosporine only for a few weeks that I anticipated will be the exacerbation after the patient is stopping prednisone, and then I would do a taper. So in 4 weeks, I'm stopping the cyclosporine, more or less 2 to 4 weeks. And also topicals, because I had many patients that the exacerbation was really remarkable. Even sometimes they had to get to the hospital with infections. That's why I'm a big advocate against oral prednisone. Like I tell patients, it's worse than a band-aid, because when you remove it, it's really, you basically didn't do anything to help the patient. You just made the problem worse at the end of the day. So I don't think this is a good solution. And now that we have good drugs, I don't think we need it. It was good for a period of time when we didn't have anything to treat them. But now that we have other drugs, I think we don't need to go into that solution.
Those are enormously good points. I'm just wondering, Emma, what dose of cyclosporine do you use? Do you use a high dose or a low dose, or what do you consider?
That's an excellent question. So I use I would start with the 3 to 4 milligram per kilogram in these patients. I would not go to the 5 milligram per kilogram because it will be hard for me to taper in 1 month. So just because of that, if I go longer term, then I will start with the full 5 milligram per kilogram. But in 4 weeks, it's kind of hard to start with the full dose and do the taper. So I kind of choose an in between, and it worked for me most of the times. Yeah, but it's interesting how our experience is so similar, even though you see guidelines are a little bit different, and also the approved drugs are a little bit different in most countries. We hope that several drugs that just recently got approval in Japan and Europe will come also to the United States very shortly, the JAK inhibitors. There are some questions that I want to engage the audience and you. So, what do you do if you have a case where you're not sure about the diagnosis of psoriasis versus AD, like psoriasiform dermatitis? Um, I have many patients like that. I have to say, and many times I'm not doing a biopsy, but sometimes I actually do a biopsy. In my clinic, I do a biopsy only when for example, I decided that it's likely atopic dermatitis. I will treat with an atopic dermatitis drug, it's not working, or the other way around. When I treat with a psoriasis drug and it's not working, then I definitely do a biopsy, and then I think we need to consider other diagnoses as well. But what do you do in these cases?
Well, I completely agree. The biopsy is not the answer. And I just think we need to acknowledge that there are these overlaps, or patients that have a psoriatic phenotype, so their eczema is expressed in a different manner. And they're just not, in the textbook categories that we like them to be in, but we have to treat them with what we have. So basically, here it's worth trying if it's more an AD, distribution and pronounced itch. Go for an AD drug. If it's more psoriasis, not that much itch, and a slightly different location, go for psoriasis drug.
Yeah, 100%. And Kenji?
I agree. But in Asian situation is a bit different. Because the psoriasis frequency of psoriasis is much lower in Asian population, and it's usually the diagnosis of psoriasis is quite clear compared to Caucasian patient. And another supporting tool to make a diagnosis of atopic dermatitis is we sometimes occasionally measure TAC, that is a type Th2 chemokine, which is approved by Japanese government to measure, but I think it depends on the country's situation. But in Japan, it's biomarker is quite useful.
And Kenji, in what percent of the population of atopic dermatitis patients is a TARC increased? And does it differentiate between patients, for example, with mild, moderate, and severe AD?
Um, TAC is one of the biomarkers. For some patients, TAC level is not so high, although the clinical symptoms is severe. So, but in a single individual, the fluctuation of TAC usually proportional to the severity of atopic dermatitis. So that is a useful tool, but TAC is not the best biomarker so far.
I understand. So it may not be good necessarily to differentiate among patients, but in a single individual, it's a good tool to actually follow long term. Got it. Yeah, no, I think it's useful. I wish we had it, but yeah, I know it's only approved in Japan. But we do in the United States, sometimes we use LDH, for example, that is available. What do you use in Europe, Jacob?
And nothing at all. We have the same experience. LDH is good, and we can see following dupilumab therapy, it drops. So I think it's worth trying, but we actually don't do it.
Yeah, no, the same. So we talked about skin biopsy needs, and I think we are really aligned here. But what do you do if you treated a patient with moderate or even strong potency steroids, topical steroids for at least 6 weeks or more than 4 weeks? Are you doing a biopsy? if the patient didn't respond?
So first of all, I never use very potent topical corticosteroid to an AD patient. I really don't like that. The skin is so permeable, and I don't want, atrophy. I don't want systemic absorption. So I just use potent. If it doesn't work, then I start asking about, how much was used. But I can't really come across any patients yet where when my nurses have, applied the topicals, that it doesn't clear. We can clear almost everything. It has to do with dose. And let me tell you, we use 25 to 30 milligram per day. That's a universal application. So it's high amounts, and then it works. I can't remember when it didn't work, but it's not a long-term solution.
So Jacob, a follow-up question to this. When you say your nurses apply, so you mean under hospitalization or day hospitalization? This is a concept that we don't
Yeah.
have in the
Yeah.
United
So
States.
it's
That's why I'm asking.
day hospitalization. So we rarely put anyone with 80 in the awards anymore because we can manage it as a ambulatory
And
patient.
Kenji, in Japan?
Nothing really to add, but for very potent topical steroid, we use in a very acute, exacerbated situation, but only short period. But other than that, I don't have anything to add to Jacob.
And I also agree. I think, and that's a very good point, that usually when, particularly when somebody else applies, since it's hard to apply on areas like the back, usually AD can clear, but it's not sustainable. People cannot continue applying huge amounts of steroids all over the body. That's why we need these systemics in this population. And I think after several weeks that nothing changes, definitely, I think a biopsy we need to think about, because we need to rule out, you do not want to have a patient with a mycosis fungoides, a form of a skin cancer that you treated all the time with topical steroids, and definitely you do not want to put these patients also on a drug like dupilumab or other drugs that are not suitable for this indication. So very important to do a biopsy when you are in doubt.
And in particular, cyclosporine will, elicit an MF. So be careful in elderly where you're not sure about the diagnosis. I wouldn't recommend cyclosporine.
Yeah, no, 100%. And we all see these patients that have atopic dermatitis, but they also have a contact dermatitis. And both Jacob and myself, we are also doing patch testing. So I have to say, I like to do patch tests in atopic dermatitis patients early in the basically early in the game, early when they come to see me, because first of all, I like to determine whether it's AD alone or if they also have contact dermatitis. And for example, if I give them dupilumab and if they have facial rashes later, many times it is due to the contact dermatitis, not something induced by dupilumab. So because we need to remember their AD will be cleared, but not the contact dermatitis likely. So I think it's important to do patch tests to try to differentiate what is their AD, what is their contact dermatitis, and think about removing the allergen. What is your experience, Jacob?
I completely agree. And especially you talked about adult onset AD, those that come with worsening, late teens, early 20s, that there I identify the contact allergens. We all, and just a brief note on the immunology, I know Kenji will cover this soon, but we know that once you have this Th2 mirror or a Th2 profile, then if you patch test or you get contact allergy, that will just worsen that Th2. So the skew is there, the immunological skew is there, and all contact dermatitis will just worsen AD, but you can't really tell it apart.
Mm-hmm. Completely agree. And Kenji?
Yeah, I totally agree. We often use contact patch test for atopic dermatitis patients, and especially in adult onset, as Jacobs mentioned, because chronic contact dermatitis lead to very similar phenotype of atopic dermatitis, which is sometimes called HAPTEM atopy hypothesis.
Yeah.
And also some of the AD patients got facial erythema after dupilumab treatment, and some of the patient is a kind of contact dermatitis and atopic dermatitis mixed, especially contact dermatitis to facial area. That is one of the possible reasons why some of the AD patients got facial redness after dupilumab treatment.
I completely agree. So now, Kenji, we would like to hear from you. What are your thoughts?
Okay, so my name is Kenji Kabashima from Kyoto University. So today I'd like to talk a bit about my thought on managing AD, understanding targeted therapies, especially in terms of adult and pediatric AD patients. So this is a scheme of the pathogenesis of atopic dermatitis. We already know that IL-4/13 play a major role for the development of each atopic dermatitis, what we call type 2 inflammation. IL-4/13 impair barrier functions, and also induce itch, and also barrier disruption resulting in microbiome dysbiosis. So we can say that all AD subtypes share robust Th2 activation. However, some AD subtypes may require additional cytokine target to effectively treat the disease, such as possible IL-22 or IL-31. And so let me explain a little bit about the effect of targeting cytokines for atopic dermatitis. One example is dupilumab, anti-IL-4 receptor antibody, approved in US, UK, and other Europe, and also in Japan, and aged more than 6 years of age with moderate to severe AD patients. Most common adverse side effect, as we described, injection site reaction, dry eye, conjunctivitis, blepharitis, eye pruritus, or herpes. So the long-term use of dupilumab shows sustained efficacy and incremental improvement of AD signs and symptoms. This is an example of adult AD patient with moderate to severe AD. Phase 1-3 study were enrolled in an old study, and at week 172, every week 300 milligram dupilumab treatment lead to 98%, 94%, 82% achieved 50, 75, 90% reduction from the baseline in EASI score, and other markers also proportionally decreased. And this is a long-term treatment with dupilumab in patient with age more than 6 and less than 12 years with moderate to severe AD patient. Similarly, with adult, IGA 01 is 44%, and mean percent change in EASI reaches 85.7%. This is really remarkable findings. And another example is targeting IL-13 only, tralokinumab, approved in Europe and Canada and UK. And extra 1 and 2 study demonstrated that, as you can see IGA 01 is reached 15.8%, and extra 2 shows 22.2% of IGA 0 and 1, and also age 75 reaches 25%, and also 33.2%. And most common adverse effects include upper respiratory tract infection and conjunctivitis. And another drug targeting IL-13 is lebrikizumab. Similarly to tralokinumab, phase 2 randomized clinical trials showed effect in atopic dermatitis at 16 weeks. IGA 01 response is about 40%, and EASI 90 is about 40%, with lebrikizumab 250 every 2 weeks. And most common adverse effect include upper respiratory tract infection, nasopharyngitis, headache, injection site pain, and reaction. And another biologics targeting IL-31 receptor, nemolizumab. This is an example of phase 3 clinical trial, modified ITT population. Change in VAS score is targeting each is 42.8% decrease of VAS scratch score compared to placebo 21.4%. And also change in VAS score up to day 15 is 30.4% in nemolizumab group. And most common adverse effect includes shown in this slide. Sure. So then we should move on to the audience Q&A. And the first question is, does the cytokine profile of AD change from youth to adulthood? I think Emma and Jacob has a strong knowledge on this. So Emma, could you start?
Of course. This is, I think, a really important question, because we need to treat patients with atopic dermatitis throughout life. And atopic dermatitis is a disease that is slightly heterogeneous. While the type 2 immune axis or Th2 immune axis is commonly upregulated in all the subtypes, there are differences between infants to children, adolescents, and adults. And for example, the Th17 axis is stronger early on in life in infants, decreasing later in life. But again, I think the important thing for us to remember is that the Th2 axis is elevated across everybody, and actually is elevated already at the infant level, including in non-lesional skin, not only in the lesional skin, but children that have it or infants that have it moderate and severe, it's already elevated in their non-lesional skin, supporting perhaps the use of systemics when you have a severe disease also in children. Although in that population, sometimes we do manage only with topicals. So we need to think about that. What is your experience, Jacob?
I second everything you said. The only thing I could add is that what I notice as a clinician is how flaring AD is in children. So there's something we haven't studied sufficiently, I think, what happens during these moments of extreme flare. Perhaps it's just that the threshold level for exploding is different, but something happens there. And I agree, what's important for us as clinicians is that if you inhibit Th2 pathway, you will solve most of the problems of all age groups. But there seems to be something about the children, something with, as you said, Th22 and 17, and it's just different.
So what do you think are, how are you treating using biologics and in general, I think, systemic medications in young population? What do you think are the advantages or disadvantages?
Oh, tough question. I think it's an advantage that we have something which is very, useful and efficacious, and it's something where we can, control the injection every other week, and then, complete parental control and also, clinician control. Some of the challenges is that it's an injection, and some children, this is really not their the first wish, if you will, and they would prefer an oral solution.
Yeah.
But it's my impression overall that this, goes very nicely, and I have very few children that complain. Let me put it that way. And also remember that they don't need all the blood monitoring. At least I don't monitor my children, which I had to do with methotrexate, with azathioprine, which we use. Not too rarely we saw changes in leukocytes, and it's just, so I think the trade-off is so good because of the efficacy of dupilumab. So yeah. What about you, Kenji?
Yeah, so in general, I agree with you. So biologics, dupilumab is available for young kids, and this is very strong and so far not so serious side effect. So compared to, especially compared to oral prednisone or other oral immunosuppressants. And maybe the another advantages of using biologics is if we can treat severe AD patients early phase, and they may which may prevent the development of allergic or atopic march. So there are still we still need more evidence to support this data, but we expect that early intervention of atopic dermatitis with biologics may prevent the development of other allergic march such as asthma.
Good point. I just want to highlight what you said about safety. Like it's a very safe treatment. That's incredibly important in pediatric patients.
Yeah, no, I completely agree. And what are you doing with pregnant women? How would you treat a pregnant woman with severe atopic dermatitis? For example, dupilumab, my feeling is that it's safe in pregnancy, but there was not a formal study, so I cannot actually tell a pregnant woman, listen, I 100% think it's safe. It's just that, there was not a formal study. So I myself would recommend phototherapy, but there are some pregnant women that would not stop dupilumab. So what is your experience?
So we studied, the nationwide use of various medications in pregnant women with AD, and we saw that they are treated with topical corticosteroids, phototherapy, as you said, and sometimes with cyclosporine. And those are the typical go-to drugs. In the European Atopic Dermatitis Task Force, we actually published a paper where you can see all the safety aspects, and this is also what's recommended. Dupilumab is mentioned in that position statement because we have no biologically or mechanistically reasons to believe that it could pose any problem for the pregnant. But as you said, Emma, it's not, there are no studies, it's off-label. But if you have this very severe AD patients, then that has a consequence also. So it's a trade-off.
I completely agree. Yeah. So I many times leave it to the women. I tell them that I had some examples of women that didn't stop dupilumab, and I have quite a few, and actually delivered healthy babies. There were some pregnancies also in the trials, but I say that I cannot actually suggest it officially because it's not in the label.
I totally agree with Emma and Jacob. And only additional treatment for pregnant patient is antihistamine, although we know that it's not so effective.
Yeah. So, what is the earliest age that you'll put a child with severe atopic dermatitis on dupilumab? Like, when would you give up on topicals in such a child?
I think it has to do with adherence. If you have good cooperation with the parents and they have understood your instructions and carried them through, then if that doesn't work, I think you should, as soon as possible, move to a systemic treatment, even though the child is not very old. So before dupilumab, we have children 2 to 3 years of age who are on methotrexate, who are on mycophenolate, mofetil, cyclosporine, so very, very young children. And that has to do with the fact that this is a chronic disease. It has very, very tremendous negative impact on the child's well-being and development. So therefore, I think if we have good treatments, if they're safe, they're given under the right circumstances, there is no lower age basically.
Yeah, 100%, absolutely. And Kenji?
Yeah, so I totally agree with Jacob, but the only problem and the only difference is in Japan, the Japanese government do not allow to use it less than 15 years old. But I agree with Jacob. We would like to start as much earlier age as possible.
Yeah, I think so. Myself, I discuss it with the parents, and many times I think the fear of some parents are, oh, doctor, will my child need to take it forever? So I say, listen, we currently are not talking about the future, but we need to give the child the best option to potentially outgrow the disease. And that means to treat it well. Look, the child is not performing well, cannot sleep, the entire family is affected. So first I'm telling them, let's worry about what happens now so that your quality of life will improve, the quality of life of the child will improve, and the child will perform better in school. And then we'll think about the future, but we need to think about a safe means to treat the disease now and for a period of time. And then many times, there is some discussion with the parents because they want to try to space out the drug more. I'm sure you have the same. So it's we basically say, let's first control it and then we'll see. And many times they like what they see and then they don't want to stop it anymore. But in the beginning there is that negotiation.
I think these are universal behaviors.
Exactly. Yeah. So, Jacob, why don't you tell us your thoughts on patient care?
That'll be my pleasure. So I'm from Denmark. It's Scandinavia, Northern Europe, and the winter is coming. But here's before it comes, we can make this presentation. So let me see here. So basically, we have been across already this about there's the patient and there's the clinician. So it really is a collaboration between the two, and it requires good communication and education. So patients, they should, describe the problem. We should listen carefully and, very often give it time, especially with the first consultation. I think it's important to allow enough time to get a good relationship with the patient, because remember, these have been sick, since very early childhood, and they have probably met a ton of doctors and have met a lot of disappointments. So I think if you are one of the last instances or one of the number 2,000 doctor they see, it's important to build this relationship of trust and where they think you can actually manage their disease and do a difference. They should, of course, attend to the recommendations, but for you, it's important to really be transparent about side effects. And here I think it's important to show the patient that just because it's in the SMPC that there is an adverse event or side effect risk, you have to think about absolute risk. Is this something that will happen commonly or will it be rare? I think that's very important because patients just read some safety issue and they stare at it. They don't think about how frequent it is. Sometimes I even bring up, the risk of flying, that you can have an accident, but it's very uncommon and you don't fear it. That's why you get yourself into the plane. Then I think patients should be presented to the many options. And of course, they should choose. As Emma said before, it's really up to them. We're just a consultant in this sense. And then they can try it out. And we should then try to adopt and educate around it and give our expert opinion. And then that's basically it. And as I'll explore on some of the next slides, we should actually also try to establish some treatment targets to get the best treatment results. So what's important is to understand what patient needs are. And we have, unfortunately, very few studies that have examined this. Here is a very recent publication from Germany, a cross-sectional study where patients were asked about their needs. And as you can see, itching is part of all of this. Also pain, which we know is closely associated now with itch. And then there's have confidence in therapy. And then there is this, having control, regain control of the disease. And basically, I think this is important. We need something that reduces itch, long-term solution, and the patient can sleep. So that's the requirement of an AD treatment. When we ask the patient about how important it is for them to have complete skin clearance or almost complete skin clearance, those are the exact wordings from the validated IGA scale that Emma presented before. We've actually asked patients, 4,000 adults with atopic dermatitis, about this, all seen in a hospital setting. And what we can see when we compare it to psoriasis is that there is a stronger need among AD patients for obtaining almost clear or complete skin clearance. And also we see a severity-dependent association. So those with the most severe disease have the strongest requirement or desire for this. And also we see an association between hand and face eczema, probably indicating that these are visible areas that lead to cosmetic complaints and sufferance. I mentioned topical corticosteroid phobia. This is very important. Here's a systematic review published in some years ago in the JAMA Dermatology. And there is no meta-analysis done in terms of getting a number. What you can see is that topical corticosteroid phobia is very common. So we need to address this in most of our patients. Of course, those with mild disease where this is the main treatment, but also in those patients with more moderate to severe disease where we have combination therapy. They need to understand it's a safe product, and you, of course, as a clinician, have to use it in a safe way. Now, some years ago, one of my colleagues made a very interesting study. So all topical prescriptions in my country are collected at the pharmacies, and we can really see whether if the clinician has made a prescription, whether it's also collected at the pharmacy. And what we found out here was that eczema is actually one of the worst diagnoses in terms of patient adherence. And then we found some other interesting findings. For example, if it's a junior physician, the patient is less likely to go pick up a prescription. We can also see here I have the initial visit. There's a higher chance that the patient will actually go to the pharmacy and collect the prescription that you gave them. We can also see that for the youngest children, it's the worst. And basically, this has to do with the parents making a decision on behalf of their children. You know, a topical corticosteroid is not safe for my child. And then also, we can see that systemic, if you prescribe them a pill, there's a higher chance that they'll go collect it compared to a topical solution. So what happens? Well, I try to explain them how safe a topical is, or it could be a systemic treatment, but there's so much confusion. When they leave my office, the last thing they hear is the nurse saying, remember, just a thin layer. And then they have been used to all these different treatment regimens where we know, noted on paper how you taper your treatment, and it just gets so confusing. And some physicians even recommend mixing it with an emollient. Now, the steroid scare can actually be measured. And what's interesting is that pharmacists have the highest topical corticosteroid phobia. So what happens when patients come to the pharmacies is that some of the prescription gets changed, or they get more warning about how dangerous topical corticosteroids are. And here in a study from I think it's from Belgium, about 40% of pharmacists actually reported that they would change the topical corticosteroid prescription. The good news is that the same authors made an additional study and showed that after education, pharmacists actually improved the way of handling and communicating topical corticosteroids. But let's move to systemic therapy in adults with AD and psoriasis. So this is a study from my country. We had 4,000 patients or adult patients with AD and 4,000 with psoriasis. And we examined the use of the systemic medications to treat these diseases. And what you can see is there's huge undertreatment of atopic dermatitis, even when we looked at those with severe disease. And this is based on a PO score. So the score at the severity scale that was introduced previously by Dr. Gottman. In psoriasis, you can see that we have much better treatment prescription habits, basically. But atopic dermatitis is different. But now we have more efficacious treatments. We would expect it to increase, but we have to redo the study in some years. What's interesting here is also if we try to look at the DLQI, so that's the life quality of the patients, we could see that those with the worst life quality of more than 10 on the DLQI scale, they also had huge undertreatment of the systemic, but as you can see, systemic steroids were used more frequently than some of the other recommended drugs. Now, again, this was made before dupilumab, so I hope that the data has changed when we revisit them in some years from now. If we look elsewhere, we can see that in France, for example, there's the same undertreatment of AD compared to psoriasis and chronic urticaria. So the situation is like that. I've seen study data from Israel showing the same pattern. So something seems to be wrong with the way we manage AD patients. So we talked about communication. One important thing is also to start defining a treatment target, because I think that at least I'm guilty, and some of my colleagues I'm sure also are, of being used to just, doing what was best, do with what you had, and then try to improve. But now realistically, with the treatments available, we can actually define more ambitious treatment targets and try to struggle to get them and obtain them, really. And this is not a new strategy. It's something that we have seen before in rheumatoid arthritis, in type 2 diabetes, and randomized controlled studies have actually shown that it works. So if you have a treatment strategy, if you have a treatment target defined with your patient, the chances of that patient ending up with a better treatment response is much higher than if you just, do what you usually do. And the way it goes is that you have an initial visit, and then you define the treatment targets based on, all the communication aspects we have covered. And then you agree on a date to see the patient again, or a new appointment. And there you see, did we manage to get to that treatment target? And if not, should we change the treatment? Should we add something to it? And this is all something that you can do in your clinic, but we need to really make that treatment plan and target to achieve these ambitious goals. So here is just an example from rheumatoid arthritis, where you can see 3 different studies that usual care compared to treat to target. It gives very different treatment outcomes for the patients. This is something which is increasingly discussed. The European Task Force of Atopic Dermatitis have tried to do it already in a small letter to the editor. And within the International Eczema Council, we're also discussing these aspects, and hopefully we'll get some more data on this. And ultimately, we need to involve the patients, of course, because they're the one who suffer from the diseases, and they have to be brought into that discussion. But this is something that takes time. And I think I'll just skip the European Task Force of Atopic Dermatitis, all the details, but just briefly say that here are presented some of the aspects that could be included in a treatment to target strategy. So it doesn't only have to be about eczema severity and reduction of that. There can be comorbidities that are important. That could be work relations that are important, or cosmetic concerns. So many different things are part of the AD syndrome, and we need to integrate that in the treatment plan that we set together with the patient as clinicians. So with that, I think I will go to the Q&A and see what we have. And I have some good questions I can see already. And the first question is, what is greatest barrier to treating teenage population? Well, that's a good one. Emma, will you start with that? Teenage populations, how do you do?
Yeah, so I think on one hand, the teenage population wants to get better, or the adolescent that we have in front of us. On the other hand, some of them are fearful of needles. Some of them are also afraid, oh, doctor, will I need to take it my entire life? So I think it's important to spend some time with them and explain that this treatment, for example, dupilumab, a systemic treatment that is effective in this population, will allow them to lead a normal life. These are very important years for those teenagers that we are seeing. They need sometimes to apply to college. There is all this peer pressure. The looks are very important. So I think the education is very important, that this drug may actually help them in multiple domains, both socially, with the education, so that they perform better in school. I have to say that once they they understand the importance of being on treatment. They overcome most of the times the fear of needles. I have many adolescents that in the beginning they were so fearful, somebody else needed to inject them, and now no problems. They inject themselves. They even go to college and inject themselves. So I think the talking to them and explaining the benefit of this treatment. And many times they ask, oh, but doctor, can I stop? So I said, listen, let's first treat it. Let's clear you. Then we'll discuss if you want to stop. And frankly, almost none of them wants to stop the treatment.
That's great. Kenji?
Yeah, so I agree with Emma. And another thing is, yeah, I agree. Peer pressure is very strong for AD patient in teenager, and also they are um, very nervous about studying. So for them, quality of life is very important, especially for the preparation of entrance examinations and others. So for them, control not eczema itself, but also quality of life and other aspects are very important. And another difficulty in Japan may not be universe is the relationship between teenager and their parents. So sometimes teenagers want to have aggressive treatment, but parents are very nervous or reluctant to the um, aggressive treatment. So sometimes that's a problem for us.
That's the same. I was just going to say, this is something I find very important, is that you try to find out who makes the decision in that family, and that, the teenager is hurt, because sometimes we have parents making all the decisions, talking on behalf of the teenager, and you have just this introvert teenager sitting there and waiting to get out of your clinic again. So very important point. Then there's a question, how would you treat an infant aged 3 months with severe widespread AD? So this is not uncommon for us. This is something we see. What do we do? Emma, what do you do?
So, I think what I would do, first of all, in infants, we need to remember that topicals many times work. So, of course, I'll not run to a systemic with a topic with an infant. So usually I would start with a mild to moderate steroids. I would use some more potent steroids in areas that are, let's say, like canified already or take for short period of times. I advise parents to really maybe utilize the treatments a little bit more aggressive in the beginning and then taper down. I kind of like that approach rather than the other way around. I do also utilize bleach baths in this population for prevention, primarily for prevention. And for many of them, it's enough, particularly when the parents are really vigorous about the applications. But for some of them, they need other treatments. So for now, I am sometimes doing phototherapy when the child is on the mom. And for some, we need better treatments, systemic treatments, such as a treatment like dupilumab.
Anything to add, Kenji?
No, for 3 months patients, 3 months kids, we usually use topical treatment, maybe moisturizers with steroid. But we start from a strong steroid and then taper as soon as possible. But if it doesn't work, we may increase the potency of steroid, but we usually don't use the other options.
The same in my country. And I'd say, we could refer to cases where, the patients, the clinician or the parents have been too afraid to apply the potent steroids. And just to give you an example, sometimes they can have very treatment-resistant facial eczema. And then you need to go to a potent steroid sometimes to get control, even though, it's not what we usually do to put a potent steroid in the face, but this is what you got to do. You need to control atopic dermatitis and use what's there, because if you don't, you will have recurrent infections, desperate parents. So, get control and maintain it. And then there's a question here. Parents often, it's a long one, so hold on. Parents often seem to have a lack of understanding regarding the toddlers and infants that I treat for moderate to severe AD. I frequently feel that they don't understand how uncomfortable it is for their child, and as a result, it leads to some level of parental non-compliance with treatment. How can I combat this obstacle to adequate treatment? So basically, it is, parents that stand in the way for good treatment. How do we do? How do we integrate the parents in the treatment plan and have their accept?
I think it's a lot of teaching and education, and I have it all the time. Sometimes I would have parents come to me with very severely affected children that is scratch in my office that I feel like, like the child is crying, screaming, itching, and the parent is coming so that I will format a list of foods that they need to avoid. For example, that happens, I'm sure, to you guys as well. I think it's a lot of education. In fact, I even explained to them atopic dermatitis is the window to the atopic march. It doesn't start with the food allergy. It actually starts with AD. That's the source that we need to treat. And I think that education is very, very important, because many parents feel, oh, we'll remove some allergen or a food and then the kid will be miraculously better. And I need to spend some time. I think the first visit is very important to spend some additional time with the parents.
Completely agree. Kenji?
I totally agree. And in Japan, sometimes we hospitalize patients, kids, about a week, which we call educational hospitalization, how important the treatment is and other education. We spend about a week or so for their kids and also their parents.
Perfect. So I think it's time to wrap up. Emma, you will do that, please?
Yeah, absolutely. This has been a really great discussion. Really great discussion. So first of all, I want to thank my friends and colleagues that joined me in this very important discussion on treatment of atopic dermatitis and how we better care for our patients with atopic dermatitis at different time zones. We are here from United States, from Europe, and from Japan. And for you, please remember to complete and submit your post-test and evaluations for CME credit. And if you missed anything, please visit us at peerview.com/atopicderm 2021 and download slides and practice aids and watch the replay of this event. And also please join the conversation on Twitter at peerview. And we want to thank you and have a great day and good afternoon, depending where you are. Bye.
Bye.
Bye.